Okay, so the disposition for my presentation will be that I'll continue on Dr. Boyle's introduction to the subject and put that into a Swedish context. And then that will naturally lead into the objectives of this thesis. And then we'll discuss the methods and results of paper number 1 to 4, which makes up the content of this thesis. And then we'll finish off with some conclusions before moving to the discussion. So crowding, as Dr. Boyle alluded to, is essentially the mismatch between the demand for care in the ED at a given time point and the available resources, both staff and equipment resources. And it's just important to know that, I mean, at some point the ED will be overwhelmed, and there might be occasions where this happens. So a large motor vehicle accident, a bus that crashes into another bus on the highway, or a natural disaster. So that's expected to be a mismatch between demand and resources. But what crowding and the scientific sort of area of research about crowding is more about is the sort of constant daily mismatches that occur more than just occasionally. So it occurs on a regular basis and causes a lot of frustration, primarily for the staff and the patients in the ED that can't get and deliver the care that they usually want. So that's just important to know. And because this has been a trend that's been seen around the world actually for like the last couple of 30 years. So crowding in this sense was first described in New York in the beginning of the 1990s. And then it subsequently was described in Australia, and then during the last 10 to 15 years has been quite well described in Europe as well. And the area has, or the science has primarily been published in the developed part of the world, and that's likely just because that's where science are produced in the majority. In majority, so this is likely a phenomenon that's general in many parts of the world, but it's the publication bias tends to shift toward the developed part of the world. And again, as Dr. Ball said, it's fairly well established that crowding is associated with decreased quality of care. We don't get our 5-star ratings in the ED when crowding is high, and there is quite strong evidence that there's also an association with increased mortality when crowding is high. So, and when I started looking into this in almost 10 years ago now, actually, there were several reports in the lay press in Sweden about disturbing situations in many of our departments. So there were anecdotes and interviews from both patients and providers about really terrible working situations in the departments. And this was one of the things that spurred this interest in the area, because at the same time, we had no measure of how to sort of estimate crowding in Sweden. There were no real vocabulary even about how to discuss this, whether or not it was crowded. It was usually around waiting times or around the number of patients, but there was no standardized way of discussing this. And there were no systematic way of looking at this nationally either. So our governance body, the Ministry of Health and Welfare in Sweden, they published occasional, every 2 to 3 years, reports from all parts of Sweden, but they only report on average waiting times, so the length of stay in the ED, and that was averages over a year. So you get the yearly average waiting time for the emergency department A and B, and that provides some sort of information about how the ED works, but it says quite little about the state of crowding and how the working conditions actually are in those departments. And it's very hard to compare between departments. And as it's natural when you don't know how to measure it and you don't know how it looks, we had really no way of knowing if this affected our patients in the way that the scientific community or the research indicated it from other countries. So we didn't know really how crowding affected our patients. And with 10 million inhabitants, 2.5 million visits per year, about. That's quite a significant knowledge gap not to know of. So this was, and this we turn this to the objectives of the study, the thesis, so to say. So in our first study, which I'll go into, we tried to develop a measure. We need something to measure. How should we measure crowding? Because as Dr. Boyle said in the James Linden Alliance, if you can't measure it, or if you don't measure, you can't work with it. You can't work with the problem. So we needed a measure. We needed something to try and understand the problem. And then in study number 2 and 3, we wanted to get a little bit more granular look on how the prevalence of crowding was nationally. And in our fourth paper, we wanted to see if we could see an association similar to others that crowding indeed affected our patients as well in Sweden. So this was the overall objectives of the thesis, and we'll jump into study number 1. So we wanted to develop a measure, and we did this at all five 24-hour emergency departments in Region Skåne in Östergötland, in Skåne, sorry. And so 5 emergency departments, and we had no definition of crowding, and to get around that, we used the staff assessment of crowding, because that was the norm in society. That way you listen to the ones working in the department, because you expected those to have the best overview of the situation. So we used staff assessment as the reference for crowding. So at all these 5 EDs, we asked both the head nurse and head physician to rate the crowding by rating their workload, or the workload in the department, at specific time points. And at the same time points, we collected data from the ED information system on several variables which we thought would predict crowding. So we wanted to find which of these variables in the information system could be used to predict the crowding as assessed by the staff. And then we did a separate collection in 2 of the EDs, in Malmö and Lund, to try and replicate the results from the first larger data collection. And what we found was that if we combined the number of patients with their medical acuity together with the collected time which they had spent in the department and the average waiting time in the department for a physician, if we combine them into a score, a mathematical model, we could actually quite well predict the assessed workload. And we term this the Skåne Emergency Department Assessment of Patient Load, or the SEAL mnemonic, because acronyms is important in science as well. So we had the SEAL model, and when we just correlated the SEAL model, so you have those scores on the y-axis, so a score from 1 to 6, and then you have the workload assessments from the head nurse and physician on the x-axis. So when you just correlate those, you can see that there is a quite clear correlation, although there's lots of variability at almost any point in time. But from those 233 time points from 5 different emergency departments, we still got a fairly good correlation with an R-square of 0.51. So it's a good correlation. It's not perfect. You want to get as close to 1 as possible, so it's not perfect. But for a complex or a wicked problem, as Dr. Boyle would say, this is a fairly good correlation. It's better, or as we hoped to get, and it's definitely similar to the other models which have been proposed, like the NEDOX or Edwin score. So the preliminary results, or the results from the first study, indicated at least that this was a promising model. And just that, also as Dr. Boyle alluded to, I'll just give a brief overview of the model development in general. So usually you have a derivation phase where you collect. This is where you try and define your variables that you wanted to collect, you want to combine into a model. And then you have a validation phase where you try and replicate the results. So you want to collect new data and check the model again to see that they are replicable. So it's just not a statistical chance that you got it from the first study. And preferably you want to do this in a larger scale as well. So you want to try it in different emergency departments, not just as a different data set, but at different emergency departments to see that your findings are generalizable. And finally, usually you want to use this model in some sort of decision tool or decision aid. So you want to help staff work against workload or with workload. And then you want to do an implementation study or implementation phase, because you want to see how your model is used in real life. Because it might be that it's used in another way than it was intended to, which may lead to unintended consequences, which you want to know of. So what we did in the first study was really a derivation and internal validation. So we derived it in all those 5 emergency departments, and then we validated it in 2 of the emergency departments. And then we've done an external validation, so tested the model in another set of emergency departments. And this is not part of the thesis. And then we haven't done the implementation study, which are actually planned after this thesis, but those are not important. Those are not done. So to summarize from study number 1, we proposed a model which seemed to work in this first and second phase of model development, and we did this in those two parts of the model derivation. So we had something to measure at least. So then we moved to study number 2 and 3, and I'll combine these because these essentially use the same methods and the same data set. And this is where we wanted to see if we can get a more granular view of the national state of crowding in Sweden. And we did this by collecting data on crowding, and we used the same reference as in the first study. So we asked the staff in the emergency departments to rate the crowding at a given time point. And then we also collected data on occupancy rate. So occupancy rate, or occupancy as it was said in Dr. Boyle's presentation, is a very common way of measuring crowding. So you just divide the number of patients at a given time point by the number of treatment beds and get a simple ratio. And the closer it is to 1 or over 1, then it's defined as crowding. You have more patients than you have treatment beds in the departments. It's simple, it's intuitive, and it's easy to calculate. So we collected that as well. And then we collected data on our patients. And specifically, we looked at the number of patients waiting for an in-hospital bed. And these patients are usually termed as boarding in the emergency department. So they're in the department, but they're finished and actually just waiting to get into the hospital ward. And this is also a metric which is usually reported in context of crowding internationally. And finally, we also collected the data on the number of staff. So we want to know something about our resources. What resources do we have in relation to the demand? So we collected the number of physicians and the number of nurses and the number of advanced nurses as well. And we did this during 24 hours at 5 time points. So it was quite a short collection period. It was only 24 hours. It was a day in May in 2018. So it was a short collection period, and it had to be a trade-off between getting as many departments as involved as possible and getting as long collection period as possible. So we had 24 hours, and we aimed to include all AEDs in Sweden. So 10 million inhabitants, 72 emergency departments. And we did fairly good. We got 50%, so 36 emergency departments, so just 50%, or exactly 50% of the departments return complete data for us to analyze. And as you can see in the map, there is a fairly good geographical distribution of the departments, with the missing departments denoted as an X in the graph or in the picture. And then you have the geometrical figures denoting the size of the emergency department and the type of the emergency department. So we were fairly happy with 50%. We would have liked to have more, but we did get to 36 departments. And this is a simple graph of just the median number of patients at a given time point in these emergency departments. So it's a median divided by hospital type. So academic, which are the large academic tertiary care centers in Sweden, and then we have the urban centers, so usually around larger cities, and then we have the rural departments. And as you can see, there is a clear circadian sort of trend in this. So we have the lowest amount of patients in the early mornings, the late nights and the early mornings, and then it steadily rises until late afternoon, early evening, and then starts to decline as well. And this was very unsurprising because this trend has been shown over and over again from all parts of the world. So this was really unsurprising. What was a little bit more surprising, though, was in the bottom part, you have in dark red the number of patients, median again, that are boarding in the departments. And what you can see, there are fairly low numbers, but they're prevalent, they're present at almost every time we measure. There were generally more patients boarding in academic centers, but there was still patients boarding both in urban and rural departments at several time points in median. So some will have no patients boarding and some will have more patients boarding. And this was just 24 hours in a quite randomly selected day in May in Sweden. So this was a little bit surprising to us and indicated that this is not just a problem for the large academic centers, which we actually maybe thought a little bit before, but it was actually present in several other departments as well. And then when we moved to crowding, so we measured crowding in two ways, by staff assessment of crowding and by the occupancy rate. So when we moved to those different scales, by staff assessment, about 20% of EDs were crowded at least one time point during this 24 hours. And by occupancy rate, about 30% had an occupancy rate over 1, which is a common way or established way of defining crowding. So when you have more patients than ED beds, then by definition of the occupancy rate, then the department is crowded. So by both metrics, at least a substantial part of the EDs were crowded at least one time point during the day. And there was some discrepancies. And this was a little bit intriguing and actually led to the third study. So until now, we have discussed the second study. So now we're moving to the results of the third study. So I wanted to dig a little bit deeper in this difference between the occupancy rate and the staff assessment. So I did this initially by just plotting these. So you have the workload assessment on the y-axis and the occupancy rate on the x-axis. And as you can see, there is clearly a visual correlation. So as occupancy rate increases, so does the staff assessment, and the other way around. But the correlation isn't terribly good. It's with a coefficient of determination of 0.36. That's decent at best, and not close to the 0.51, which we got for the SEAL model, between the SEAL model and the workload assessment. So what I then did was I looked into the occupancy rate. So occupancy rate just uses two metrics, so the number of patients and the number of treatment beds. And when I looked at the number of treatment beds between EDs in the raw data, there seemed to be some substantial variation. I mean, some EDs are larger and some EDs are smaller, that's known, but even in between larger EDs, so EDs that had the same number of patients seen daily, there were quite large discrepancies in the number of available treatment beds or the number of treatment beds in that ED. So I checked this by just dividing the average number of patients seen in an ED. So if an ED saw 100 patients per day and had 25 beds, I would divide the 100 patients by 25 beds and get a sort of a turnover rate. So that ED would have to turn over 4 patients per day per ED bed. So this got some sort of baseline. And the mean turnover rate was 4. So in mean in Sweden, there are 4 patients per bed per 24 hours in an ED. The lowest had 2 patients per bed. and the highest had 9 patients per ED, per bed per ED in per 24 hours. So that's quite a large difference. So that's a 4-fold difference between the ED with 2 patients. We'd only had to turn over 2 patients per bed per 24 hours compared to the highest, which was 9. And so I thought that this might actually explain some of the differences in occupancy rate between EDs and the workload assessment. So again, we move back to the other scatter plot, and then I plot this, I color this. So now you have a third sort of vector or dimension. So you have the color of the dots indicating the turnover rate of that ED. So blue denotes an ED which has a low turnover rate, so 2 patients per ED per day. And when you go up to gray and red, you get to the high turnover rate EDs, so up to 9. And then, at least I thought, I visually saw 2 clusters. So you have a blue cluster in the left and a red cluster in the red or gray cluster to the right. And when you just split the data set on the average, so the average was 4 patients per bed. When you just split it, you get 2 quite distinct clusters of ED. So you get 1 ED here, 1 cluster here, and 1 cluster here. And the correlation then between the occupancy rate and the workload assessment gets much better, or better at least, than 0.36, which we had initially. And when you put the occupancy rate relative to the turnover rate, so you divide the occupancy rate at a given ED by the turnover rate, and you correlate that with workload, you get a far better correlation for the whole set. So you get 0.5, you get an R-square of 0.56, which is actually better than we got for the SEAL model in the beginning. And there are a number of other factors that may explain this difference. So there might be that 1 ED have lower staff, and that's what's causing a higher workload or differences in workload assessments. So we tried to adjust for this. So we adjusted for the number of staff, we adjusted for the type of ED. Is academic different than rural or urban? And then we also adjusted for time point during the day. So is time point any difference? And still adjusting for all that, there was still an indication that the turnover rate influenced the workload assessment at a given time point. And what that actually means is that if you have 2 EDs, they have markedly different turnover rates. So one has 2, one has 8. If you have the same occupancy rate at those 2 EDs, so say 1, for example, both EDs have 1 in occupancy rate. There are equal number of patients in relation to the number of treatment beds. Then the ED with a low turnover rate in the above will rate that occupancy rate higher, will rate their workload higher than the ED with a high turnover rate. They will rate the same occupancy rate, or they will rate their workload lower, even when adjusting for other factors that may influence the workload. So, and this has some, when you think it through, it has some face validity. And the only implication, or the implication really, is that if you're comparing, you need to know how the measure you are comparing EDs with each other are influenced by ED specific factors. Because if you look at this, you can compare occupancy rate, and it would be the same. By the same definition, it would be same between the first and second ED. But if you look at staff assessment or are interested in that, you would have different results. So this is important when, at least when comparing occupancy rates over a number of EDs, not just looking at one single ED. And this was essentially the conclusion. So the first conclusion from study number 2 was really that occupancy rate is, or crowding is prevalent in many EDs in Sweden. and that there are important factors that might influence the metrics that we use when comparing crowding, which we need to know of when comparing on a national level, for example. Okay, so moving into the last study, we wanted to see, well, does the crowding, which we now hopefully can measure, does that influence our patients? And specifically, we wanted to look at mortality. So we looked at 7-day mortality after an ED visit. So to measure crowding again, we used our derived model, and actually we modified it to account for differences between the EDs and in which metrics we could get out. So we actually had to refine the model and simplify it a little bit, and we could show in the study, which isn't part of the thesis, that we can actually estimate quite good by just using 2 of these metrics instead of 4. And then we used the occupancy rate as well to have something to compare it to. And when looking at crowding and some sort of adverse events, because there are different adverse events, there is likely differences in how these adverse events happen. So if you just look at waiting times, for example, it's likely that even when crowding increases from very low levels, waiting times will increase, and they will continue to increase. And then when crowding gets really severe, then they might go out the roof. So, but looking at some other important event, like, for example, the time to get to the angiogram for your myocardial infarction, that will likely be prioritized in the ED by the staff, and they will try to compensate for increasing levels of crowding and make sure that the time it takes to get to that angiogram, that will be as low as possible for as long as possible. So they might care a little bit less about the waiting times, so they will leave the waiting times going up to compensate and to make sure that the time it takes for you to get to your angiogram will continue to be low as long as possible. And for the severe adverse events like mortality, increased mortality, that's likely to happen even further down the crowding scale, so to say, and will likely not increase when crowding is low or moderate, but when crowding gets severe. And as Dr. Boyle said, this is not really the cutoffs where these events start to happen, hasn't really been studied well. So we had to define, to study this, we defined arbitrarily where these cutoffs were. So usually it's quite common to define 3 sets of crowding. So otherwise, either the ED has no crowding, low crowding, which denotes the green, and then you can move on to the moderate crowding and then to severe crowding. But where exactly these cutoffs or transitions go isn't really established. So we arbitrarily defined 0 to 85% crowding on a scale from the maximum to the lowest to be no or insignificant parts of crowding in relation to severe outcomes. So waiting times may increase in this part, but that's not really what we're interested in. And then we define the top 5% of crowding levels to be the exposure of interest. That's where we think mortality increases. So we had, for this last study, we had 6 months of data from 6 EDs. And what we did, and what I did to try and identify just the patients we were interested in, so those exposed to extreme levels of crowding, I did for all these 6 months of data, I took each hour of the day for 6 months. So for example, let's take 8 to 9. So the majority of days will have no or moderate crowding at this time point. And for a few days, we'll have moderate to severe crowding, and then really severe crowding. So I define this as the top 5% of those hours or those days, so to speak, for 8 to 9. And then I did this for each hour of the day. So I get a certain number of days for each hour when crowding was really high or severe, so the top 5%. And then I compared patients that arrived during these red hours on these days compared to the green hours. So I just compared the red to the green, basically. And I did a Cox regression analysis to try and adjust for other factors that may confound death or the adverse events, or the serious adverse events. So that would be the chief complaint, what you came to DD for, how sick you were when you come to DD, so the triage acuity level, whether you were admitted to hospital, whether you were transferred by EMS, and some other factors as well to try and adjust for some things that might influence mortality. And still, by adjusting for that, for our 6 months, our 6 EDs, so 3 in Region Skåne and 3 in Region Östergötland, we found an increased 7-day hazard ratio by a Cox regression analysis of 0.05%, which would translate in our cohort to about 8 patients dying earlier just by coming to the ED on hours with severe crowding. And if we sort of extend that phenomenon and our results to the whole of Sweden, that would translate to a conservative estimate would be about 100 patients per year that has an increased 7-day mortality as a result of crowding. And this is somewhat supported by evidence from 2 other studies that's been just published the last year from a group in Stockholm as well, which has seen the same or the similar trend. And this was seen both by using the modified SEAL model as the definition of crowding and by using occupancy rates as the definition of crowding. So to conclude, from the first study, we proposed a simple metric, the SEAL model, to measure crowding in Sweden. And in the second and third study, we could show that crowding and boarding was indeed prevalent in several emergency departments in Sweden. And that time and ED factors, so both the circadian sort of distribution and differences between EDs are important when comparing crowding between institutions. And in the fourth and final study, we could show an association between severe levels of crowding and an increased 7-day mortality. And by that, I want to thank both my supervisor, Ulf Ekelund, which is here, and my co-supervisor, Daniel Wilhelms, which is also here, for their unconditional support during this 4 years now, which has been an absolute pleasure, and it's been a really fun personal journey for me, and I look forward to the continued work which we plan.